Easy task.
Yes, it's a long chapter of the shoulder surgery. But Manos, thank you for your invitation. It's a very nice meeting. I'm very happy to share with you in Athens my experience in shoulder arthroplasty in 2017. The most common complication after anatomic total shoulder arthroplasty in order of decreasing frequency were component loosening, glenoid wear, instability, rotator cuff tear, prosthetic fracture, neural injury, infection, hematoma, and deltoid injury, and venous thrombosis and embolism. Yes, sorry. You can come back, please. Yes, and here. Yes, here you can see that. Perfect. Evolving trends in shoulder arthroplasty. You have new products for be better during the surgery. The platform-based design, the stemless modular shoulder arthroplasty. I mean, it's good evolution, and patient-specific guide or for glenoid resurfacing or software to help us to choose the best positioning of the base plate or the glenoid side, and to be sure to have in the right position as well. You see the different complication, the percentage of all complication, and you see the component loosening is the first one. It's a common cause of failure of arthroplasty. It's 12.4% of all complication. Glenoid component loosening is a majority, made up majority of this event. It's 3 times greater with the utilization of metal back glenoid implant compared with the polyethylene. But fortunately for us, the metal back is modify with the time. It's better and better, and we have less problem now, certainly, with that. Humeral component failure occur in 47 shoulder for prevalence of 0.2%. The glenoid loosening is different if you have a Kell or pegs as a design of the glenoid, but it's very important to check and to measure the evolutivity of this loosening. But the most important thing is to check the glenoid component seating, because if you don't have a good seating of the glenoid side in grade B, C, and D, and in grade E, you have exposure to the rocking horse effect of the glenoid component, and to have a very, very easily the loosening about that. If you have removed the component because you want to revise, it's very important to understand when you need to revise the glenoid component, and certainly if the patient becomes symptomatic and it's painful in the decrease the range of motion, it's very important to check why. It's not only the glenoid component loosening. You need to search rotator cuff insufficiency, and we have just before C. It's very important to check the low-grade infection, and offer demonstrated very well just before. The condition of the management of bone loss are different regarding the continuity of the glenoid rim, and you understand it's easy to treat a central bone defect. If you have a cortex bone defect, it's more complex to perform. And for the reimplantation, you need to have a good bone stock, and you need to have a very good secure fixation with regarding the cement mantle, and it's in this condition it's possible to don't reimplant a glenoid component, and you just put a graft into the bone defect to restore the center of rotation of the prosthesis on the shoulder to have the better effect as possible. But unfortunately, you have not the best, a good result. You have always a poor result, especially onto the mobility. For the humeral loosening, the stem loosening appear to be dependent to the glenoid implant status in anatomical total shoulder arthroplasty, and it depends also of the mode of stem fixation into the humeral shaft. The glenoid polyethylene wear was associated with the development of osteolysis of the proximal aspect of the humerus after arthroplasty. And it was a big problem for the stemless prosthesis because you don't have very poor fixation, a very short fixation of the prosthesis. And if you have polyethylene wear, you have a problem very, very quickly with the humeral component. With the stem, it's longer to appear, but it's very important to check it. And in this case also, it's very important to check the low-grade infection, because sometimes the aspect of the humeral shaft is very common for low-grade infection. For the treatment, you need to change the stem, and you need to remove the mantle of cement and to reintroduce a second stem. Sometimes you need to do that in two stages, or one regarding the ability to do. The glenoid wear is very important, and it's more frequent with the metal back, but you can see without metal back. And you see in this part, the white arrow shows the attrition of the cortex bone regarding the debris of polyethylene, and they modify the aspect of the humeral side, and you decrease the stability and the strongness of the fixation of the humeral component. You have a specific complication with the metal back. It was demonstrated in first with the first generation of metal back from Equalis prosthesis, but different prosthesis has the same problem. When you implant the polyethylene into the metal back, you can have a dissociation of the polyethylene. You see the repair, the landmark of the polyethylene, and you see the polyethylene is not in the right position, it's moving, and you have a contact metal to metal, and we have metallose after time, and you have a resorption of the bone around the humeral component and the glenoid component. It's a big problem, and you need to make the diagnostic very early and to change very early, to change the component very early. Total shoulder arthroplasty instability is a good chapter to the complication of the shoulder arthroplasty. Anterior instability depends on the component malposition, anterior glenoid deficiency, and surgical deltoid takedown, axillary nerve injury, or failure of subscapularis repair, and it's very important, and Enrico showed us very well, it's very important to dissect the subscapularis as well and to repair it very nicely to have the best effect, of course. But if you have overstuffing of the glenoid, of the humeral head, you create very easily insufficiency of the subscapularis muscle and tendon. Superior instability after anatomic total shoulder arthroplasty generally occur in the setting of rotator cuff deficiency. And in this case, the best way is to move to the reverse shoulder arthroplasty because it's a better option for rotator cuff insufficiency because different studies show to repair the cuff in the same time as the implant total shoulder arthroplasty, the result is not good enough. Subscapularis management, you have just see that before. There is no big difference between tenotomy or tuberosity osteotomy, but it's very important to repair that. And personally, I have a trick. I do every time tenotomy, and I have a trick. I use the biceps to augment the suture of the subscapularis, and I create, in this case, the tenotomy in the same time as repair the tendon of subscapularis. For posterior instability, it's very difficult sometimes, and it's very important to check during the procedure the stability and the posterior subluxation of the implant to can make some plicature of the posterior capsule. You can suspend this capsulography with the CA ligament. But sometimes you need to change the aspect of the glenoid component, and you have you make some graft posteriorly. The rotator cuff tear is a big problem, and sometimes arrive very long time after the first implantation. And the best way for that is to move to reverse, to convert to reverse shoulder arthroplasty to solve the problem of the insufficiency of the cuff tear. If you have post-operative, perioperative fracture of the humerus, the best way is to use a long stem to bridge fracture and to have a big, good fixation in the distal part of the humerus. Post-operative fracture is different. You have different type of fracture. The type A is located of the tip of the prosthesis and extend proximally. The type B is at the tip of the prosthesis without extension, but minimal extension proximally, but distal extension. And tip C is located distal to the tip of the prosthesis. You see different tip of the prosthesis, and the very best option to treat it for to the tip of the prosthesis. You can you can fix fracture with a plate and cerclage and a screw. For the tip B, you can use a long stem and to fix and to graft the fracture with bone, vascular bone. Sometimes it's necessary to do. And for distally, you can use the plate or orthopedic treatment. For the stemless prosthesis, it's easy to use orthopedic treatment to treat the fracture because it's very easy. It's more little bit complex, and I go fast. For the nerve complications, the most frequent nerve injury is at the level of the racine, the roots and the trunk. And you see here the axillary nerve around the humeral extremity. And I think it's very important to protect it during all of the surgery. Normally, there is just neuropraxy, and after time, the result is good, and it's not it's not always necessary to operate the complication. Infection, it was very nicely described by Offer-Levy. I mean, it's not necessary to go more. Hematoma is very rare complication, but is bad for infection, and it's very important to check and to treat the hematoma to decrease the risk of infection. Another complication is a deltoid injury, and it's very least commonly reported in complication. And if you have a big, difficult prosthesis to do, there is a trick, the report by Angus Wallace with osteotomy of the clavicle, just at the level of insertion of the deltoid onto the clavicle, and you can move the clavicle with the deltoid, and you increase the exposure of the shoulder, and you reduce the risk of damage of the deltoid. Deep venous thrombosis is rare, but if you have some risk, patient with risks, it's necessary to avoid the thrombosis by treatment. A recommendation for the complication, you see that it's a summary as we said just before. Thank you for your attention.